बिस्मिल्लाहिर्रहमानिर्रहीम। दिस इज़ योर होस्ट डॉक्टर अतीक और आपको मैं हाइपरटेंशन कॉन्क्लेव के एपिसोड 1 के अंदर जो है वो शामिल कहता हूँ। नाज़रीन, आज हम लोग बात कर रहे होंगे ऑन हाइपरटेंशन। हाइपरटेंशन और हाई ब्लड प्रेशर इज़ अ सीरियस मेडिकल कंडीशन that significantly increases the risk of heart failures, heart issues, brain and kidney disorders. Estimated है कि 1.13 billion people worldwide have hypertension. Or mostly they are from low middle income countries, or I'm sure data there data is showing that around 1 in 4 men or 1 in 5 women had hypertension, और जो है इसमें से 50% को hypertension का पता है और 50% को hypertension का नहीं मालूम. So viewers, today we have a very esteemed guest or speaker with us. We are very much it's our honor that we have a very renowned specialist with us, Dr. Ali Asghar Sahab. He is with us, और हम उनके साथ जो है मज़ीद we can learn what is hypertension, what are the latest update with us. Before going further, I would like to ask my colleague, Mr. Noman Wasi, to recite a few holy verse of a few verses of Holy Quran so that we can start with them. Noman, can you recite few holy verses? Noman, can you recite few holy verses?
बिल्कुल सर. आपको सर आवाज आ रही है मेरी?
जी जी प्लीज.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد. صدق الله العظيم.
जज़ाकल्लाह. Thank you, Noman. बहुत शुक्रिया आपका. Sir, viewers, so we can start with our presentation. I would like to request Dr. Ali Asghar, consultant endocrinologist and diabetologist, to please take up the session from here. मैं अपने participants को ये बताता चलूँ that we have a very renowned medical specialist with us, Professor Dr. Najmul Islam. He is also a consultant endocrinologist and diabetologist. He is with us. उन्होंने हमें join कर लिया. Sir, thank you for joining us. Dr. Ali Asghar, over to you, please.
Assalamu alaikum, everyone. Thank you very much, Atiq, for once again giving us an opportunity to talk on hypertension. Is Professor Najmul Islam also here?
Yes, he just joined.
Okay,
Just
so,
join us.
Assalamu alaikum, sir. With your permission, I would like to start the session on hypertension.
Hello, assalamu alaikum, Ali sir.
वालेकुम अस्सलाम. सर, अगर आप इजाजत दें तो शुरू कर दें.
बिल्कुल बिल्कुल इजाजत की जरूरत नहीं है.
Good.
Okay.
So let's start. This is an important session on hypertension, and when we talk about diabetes, things are black and white, pretty clear. What should be the HbA1c? What should be the fasting blood sugar? What should be the random blood sugar in different age groups? Sometimes things are pretty clear when we are dealing with diabetes. When we come to hypertension, it needs to talk about. We need to discuss as what are the diagnostic measures, what are the measures to treat hypertension. So let's move on and begin today's talk. These are some of the wonderful hospitals in Karachi where I am blessed to work at. So this is the global prevalence of hypertension. You see, globally, if you see hypertension, around 40 to 50% of the people are having hypertension in different continents. And if you see the income class, again, whether it is low income or middle income or high income, you see hypertension in all income classes. This is the prevalence of hypertension in our homeland, that is Pakistan. You see that the prevalence of hypertension is 26.3% in adults, more in urban than in rural areas. Now, this means that there is a huge burden of hypertensive people in the world. I mean, 1 in 3 adults in the world is hypertensive. If we see Pakistan, things are not too different. And this merits more discussion and more learning about this metabolic disorder. Now, what we are talking today is the importance of hypertension management with people with diabetes, and this is an important aspect in itself. Now, this is the cardiovascular disease continuum. Now, the whole point of treating hypertension or treating diabetes or treating dyslipidemia is basically to prevent the patient from developing cardiovascular disease, which is myocardial infarctions and strokes. So these are all the risk factors that ultimately goes into this whole cycle and leads to cardiovascular death. When we talk about hypertension, hypertension leads to left ventricular hypertrophy, myocardial ischemia due to thrombosis, leading to infarction, ventricular remodeling and enlargement, congestive cardiac failure, and ultimately end-stage heart disease and death. And this is why we are sitting here on a hot Thursday afternoon talking about hypertension and its management. Now, this is a very, very old study, very categorically describes that when you do not have diabetes, your cardiovascular mortality is low. But when you have diabetes, of course, your cardiovascular mortality goes up. But what if diabetes and hypertension combine together? And we have seen in studies up to 60 to 80% of diabetes patients, they have hypertension as well. And if you see, as you go from a blood pressure less than 120 to somewhere close to 200, you see a rise in CV mortality. Now, whether this is no diabetes, the gray bar, or diabetes, the blue bar, the mortality increases. But more so when you have diabetes than when you do not have diabetes. You see the blue bars are diabetes with increasing blood pressure, and the mortality is significantly going up compared to when you do not have diabetes. This means that hypertension and diabetes together make a combo which is sure shot to cause cardiovascular disease. Now, if you see this, again, in different age decades, whether you are between 50 and 60 or 60 to 70, 70 to 80, 80 to 90, the mortality is high. But as you move towards higher blood pressure, the mortality keep going up in all decades of life, whether it is because of stroke or because of the ischemic heart disease. This means that as age goes up, the mortality definitely goes up. But if you're having hypertension, your chances of going dead is earlier than if you do not have hypertension. Now, when we talk about hypertension, many a times we disregard little millimeters of mercury levels. But let us just see that blood pressure reduction of just 2 millimeters of mercury actually reduces the ischemic heart disease mortality by 7% and mortality by stroke by 10%. And this is very significant because at times we disregard these little values, but even these little numbers have a significant role to play in terms of mortality. So what should be the blood pressure that we should intervene? Different guidelines have got different insights. Different guidelines talk differently, but different paths, they lead to a common objective, and that is to control blood pressure and to reduce heart disease morbidity as well as mortality. Now, if you see this study, this is the guidelines from European Society of Cardiology 2018 guidelines. They say that anything systolic blood pressure 130, diastolic blood pressure 85, anything more than this is considered high normal. But if the patient does not have any other risk factor, this will be a low risk blood pressure. But if the patient has 1 to 2 risk factor or 3 other cardiovascular risk factors like obesity, like smoking, like increasing age, or if the patient has chronic kidney disease or diabetes, the risk from yellow, low risk, it goes to high risk. And if somebody has cardiovascular disease or CKD grade 4, even this blood pressure more than 130/85 becomes very high risk to lead to cardiovascular disease. So you see, it's not only the blood pressure, it's also the other risk factors that we have that decide our management of blood pressure and our diagnosis that particular patient is hypertensive and needs treatment. Somebody with 130/85, more than 130/85 with no risk factors is low risk. Somebody cardiovascular disease, 130/85, more than 130/85 is very high risk for another cardiac event and should be meticulously controlled. Now, this is American Heart Association guidelines, and we see that less than 120, less than 80 is normal. Anything more than 120 systolic, 120 to 129 is elevated, and more than 130, more than 80 is hypertension stage 1. So this guideline, of course, is coming from the cardiologists, and they say that, well, blood pressure should be less than 130, 80. And of course, we respect that because they are looking closely at the heart. And again, stage 2 is 140, 90 or more. Coming back to the European Society of Cardiology versus the American Heart Association guidelines, we see that the European Society of Cardiology, less than 120/80 is normal for both, but anything between 120, 129 systolic is normal for the European Society of Cardiology, but elevated for the American Heart Association. And again, more than 130, more than 85 is high normal for European Society of Cardiology. But again, the American Heart Association says, well, anything more than 130/80 is hypertension stage 1. And then, of course, they both increase their grades and stages of hypertension. So, I mean, the real thing is it more than 140/90 or is it more than 130/80? And again, I would emphasize that rather than mixing up and being troubled by the guidelines, let's make it pretty simple. If you do not have risk factors, keep it less than 140/90, but with risk factors, keep it low. So again, this is the NICE guidelines. And again, they would say anything more than 135/85 is hypertension stage 1. So this is between the European Society of Cardiology and AHA. And this is the International Society of Hypertension guidelines. And again, they would say 140/90, more than 140/90 is grade 1 hypertension. Regardless of whether you diagnose it at 140/90 plus or 130/80 plus, depending on what the other risk factors are, what is the goal in blood pressure? So essential, and this is again from International Society of Hypertension, the target blood pressure should be to reduce it by 20/10 millimeters of mercury in the next couple of months, and ideally to less than 140/90. So when it is essential to control it to less than 140/90 for many patients, but if less than 65 years, target should be less than 130/80 if tolerated, but keep it more than 120/70. Anyone who is more than 65, well, keep it less than 140/90, and even more than 80, you can let it go up to 150. So this is all about what it should be, how you diagnose hypertension. Now coming up to the treatment of hypertension, now, if anybody has hypertension with type 2 diabetes, you start with ACE inhibitors or the ARBs. If patient has hypertension without diabetes, then if the age is less than 55 and patient is not a Black African or African Caribbean, start with ACE inhibitor or ARB. But if the age is 55 or more, then start with a calcium channel blocker, and the patient is from Black African or African Caribbean ethnicity, start with a calcium channel blocker. But remember that hypertension with diabetes, you always start with an ACE inhibitor or ARB. And in even Pakistan, you start anybody less than 55, not a diabetic, you start with ACE inhibitor and ARB. That is the first line treatment. The second line is either a calcium channel blocker like amlodipine or a thiazide diuretic. You can choose any of these. And of course, the third line, if second line you have taken a calcium channel blocker, third line you can take a thiazide diuretic, or if you have taken thiazide diuretic as second line agent, you can take a calcium channel blocker as a third line agent. So this means that hypertensives with diabetes, ACE inhibitors or ARB is the golden choice. Second line, calcium channel blocker or thiazide diuretic. And whichever you take, the other one becomes the third line agent in diabetes. This is the American Heart Association. Remember, in American Heart Association says more than 130/80 is hypertension stage 1. But they do not tell you to go on and treat medically, always. What they say is, and remember, we're not talking about the lifestyle because you are all medical professionals, but lifestyle has to be there, whether it is hypertension or dyslipidemia or diabetes. Half an hour of walk every day equals to monotherapy in hypertension, according to a study. So, of course, it always starts with minimum half an hour walk every day, minimum 5 days a week, as well as dietary limitations. Even American Heart Association with a stage 1 hypertension says that more than 130/80, assess the cardiovascular risk. You can check the Framingham Heart Score or other cardiovascular risk score which are easily available over the internet, and see the atherosclerotic cardiovascular disease risk in the next 10 years. If the risk of getting a cardiovascular event is less than 10%, then just carry on with lifestyle modification. But if it is more than 10%, the cardiovascular risk, then start a medication as well apart from diet and exercise. But if the blood pressure is more than 140/90, you always start with lifestyle modification as well as a medication for hypertension. So coming back, we talked about hypertension diagnosis, we talked about the agents that can be used in hypertension, and today we are talking specifically about valsartan, and we'll talk about amlodipine, and then we'll talk about the combination of valsartan and amlodipine. So this is the blood pressure lowering effect of valsartan after missed doses. So studies say that 1 out of 5 people will miss a hypertensive medication 3 days a month. So this means that there's a tendency in patients to miss their doses. So what happens when they miss their doses? So this was a study, and I'll not go into the whole detail. What they did was, this was a 4-month study. They did ambulatory blood pressure monitoring at the beginning and at the end of the 16 weeks. And what they saw was that when valsartan was compared to enalapril, and when the dose was missed, in enalapril, the blood pressure rose, but in valsartan, even if the dose is missed, the next day blood pressure with a missed dose does not go above the target that you set for your patient. And this is important. Although the valsartan has got a half-life that is low, but it still gives a coverage that is equal to 24 hours. Valsartan 160 milligrams provides significant blood pressure reduction. So you can start valsartan from 80 milligrams, go up to 160 milligrams, and the maximum dose that you can use is 320 milligrams. Professor Islam is with us, and he's going to tell us his experience. What I have seen is that valsartan 160 milligram works the best. Very less times we need to go to 320 milligrams. But valsartan, if you're giving it alone, 160 milligrams works beautifully, and even in combination with amlodipine that we're going to talk about. So what about valsartan 160 milligrams? The results from a 3-month trial, and it shows valsartan alone reduces blood pressure more than telmisartan, whether it is systolic or diastolic. The systolic blood pressure reduction up to 18 millimeters of mercury, and diastolic 12 millimeters of mercury. Again, valsartan provides comparable blood pressure reduction when you compare it with losartan or irbesartan or candesartan. You see a blood pressure reduction that is quite comparable to other sartans in the ARB family. So when we talk about valsartan, it's not only about hypertension anymore. Any medication that we are giving has to positively impact the heart, and any medication that we are giving should reduce the cardiovascular morbidity and mortality. So what is the role of valsartan in organ protection? So, well, I mean, if you see the whole continuum of cardiovascular disease, there are many trials of valsartan, and we are going to talk about a few trials as well, where valsartan is shown to reduce cardiovascular morbidity and mortality. And in fact, valsartan is the most studied ARB that we are having today. So if we talk about different trials, there are many trials with valsartan. In fact, the most number of trials are with valsartan. Ati, can you mute other participants, please? So the most studied of the sartans is valsartan. And if you see, these are all the other sartans that have been studied as well. So we're going to talk just a few trials, and I'm not going to go into the details because of the lack of time. This is the value trial, 15,000 patients, a trial on valsartan. And it showed that there was no difference in cardiovascular mortality and morbidity compared to other medications that were being used against amlodipine. So this was valsartan versus amlodipine. But it showed that there was 23% reduction in new onset diabetes that was seen in the group with valsartan. Then comes Valiant trial, again 14,000 patients, and no difference versus captopril in all-cause mortality. So it again shows that it was as effective valsartan as the standard of care. Then the VAL-HAF trial, again 5,000 patients, and these were patients with heart failure, and we know that valsartan is being used in heart failure, especially by our cardiovascular colleagues, and we see tremendous benefits, 13% reduction in cardiovascular morbidity and mortality, reduction in atrial fibrillation and 28% reduction in heart failure hospitalization. Then there is the Jaikis heart study from Japan, which again was done in patients which showed tremendous benefit. This was again patients with heart failure, and there was again tremendous benefits as was seen with the WellHealth trial. Again, the MOWL trial showed a significant reduction in the urine albumin excretion rate, and it was thought that whether this urinary albumin excretion declines because of the blood pressure control or because of valsartan, and it was shown that when valsartan was compared with amlodipine, valsartan had a 44% reduction in urinary albumin excretion compared with 8% reduction with amlodipine. And again, the Wellmark trial again proved that the CRP, which is a marker of inflammation and is seen with cardiovascular disease, again reduces significantly when we are using valsartan. So again, this is the study from Japan which showed when valsartan-based therapy improved outcomes in patients with hypertension, coronary artery disease, and or heart failure. We see the CV mortality and morbidity going down by 39%, stroke and TIA going down by 40%, hospitalization for heart failure going down by 47%, and hospitalization for angina going down by 65%. Again, this study again shows a reduction, 23% reduction in the diagnosis of diabetes when you're giving valsartan compared to losartan. Now, there may be many theories that have been postulated, but we see that even in the study compared with amlodipine, valsartan had a low incidence of newly diagnosed diabetes when patients were on valsartan. So having talked about valsartan, I will now move on and talk about amlodipine and hypertension management. So again, as you can see, amlodipine is a fantastic medication with a fantastic half-life of around 30 to 50 hours, and it works beautifully when it is given once a day. This is the 24 hours of effective blood pressure reduction. This is a randomized trial comparing amlodipine with nifedipine GITS, which is the long-acting nifedipine in sustained hypertension. And again, when you compare the baseline with 8 weeks of medication, you see the amlodipine working better than the nifedipine GITS. So, beautifully works well in terms of reduction of blood pressure, a sustained reduction of blood pressure. Again, the same study showed the 24-hour reduction, daytime, nighttime, and morning reduction of blood pressure better than amlodipine compared with long-acting nifedipine. Again, if you see amlodipine 2.5 milligrams also gives a very sustained blood pressure reduction over the next 24 hours. And I told you the half-life is beautifully placed to more than 30 hours in amlodipine. Again, if you see 5 milligrams of amlodipine, the 24-hour blood pressure reduction in different clinic visits, whether it is visit 2 or 4 or 6, the reduction in blood pressure is significantly better in amlodipine. Now, this is the primary prevention. So what is the role of amlodipine preventing cardiovascular events? So remember, whether we are treating diabetes or whether we are treating hypertension or whether we are treating dyslipidemia, the target is to prevent cardiovascular morbidity and mortality, and that is the real goal of the whole antihypertensive treatment. So if you see the antihypertensive and lipid-lowering treatment to prevent heart attack trial, the all-heart trial, 33,000 patients with hypertension and more than or equal to one cardiovascular risk factor randomized to clorthalidone, amlodipine, or lisinopril for 5 years. And we see that all agents had similar efficacy to prevent the rate of myocardial infarction or fatal cardiovascular disease. Again, this is an Anglo-Scandinavian cardiac outcome trial, blood pressure lowering therapy, 19,000 patients, high-risk hypertensive patients with 3 additional CV risk factors. So these are hypertensive patients who are there with more than 3 risk factors and sure shot to probably go on and cause cardiovascular disease. And they were randomized to amlodipine and perindopril group or atenolol and benroflumethiside group for 5.5 years. And we see that amlodipine-based regimen had decreased non-fatal MI and fatal cardiovascular disease. Even if we see today the atenolol or beta blocker, which is sometimes we see that atenolol is usually written by prescribers across Pakistan, but if you see the hypertension treatment, atenolol is not seen anywhere. It comes up very low in the list. It should only be used to control the heart rate by cardiologists. Rather than that, if you see the treatment of hypertension, you don't see it in the first 3-4 medications that you use for the treatment of hypertension. Again, the same study, if you see, the amlodipine-based therapy was better compared to atenolol-based treatment in all secondary endpoints, whether it is non-fatal MI or whether it is total coronary endpoint, whether it is all-cause mortality or CV mortality or non-fatal heart attack or stroke. Amlodipine group was better compared to the atenolol-based group. Again, if you see secondary prevention, that this is a study comparing amlodipine with enalapril to limit the occurrence of thrombosis. Now, again, 1,991 patients with cardiovascular disease and diastolic blood pressure less than 100 randomized to amlodipine 10 milligram, enalapril 20 milligram or placebo. So now amlodipine versus ACE inhibitor, enalapril and placebo, and you see that the CV event rates were lowest in the amlodipine group, and we all know that it helps the stable angina patients, amlodipine, we know that. So amlodipine had the lowest CV event rate compared to enalapril and placebo. Again, wealth of CV outcome data. This is the PREVENT trial. Again, patients multi-center trial. We see reduction in hospitalization for heart failure and angina, reduced revascularization procedures as well, 1/3 reduction in all these things. The Camelot trial, again, if you see, this was a trial with compared with enalapril, and again, 41% reduction in hospitalization for angina and 27% reduction in coronary revascularization events. The Asghar BPLA trial and the ALLHAT trial, again, significant benefits both in terms of CV morbidity and mortality. So when we are talking about hypertension, we know that we have ACE inhibitors and ARBs, and then the calcium channel blockers or thiazide diuretics being the second and third line agents. But the combination treatment is now coming into the guidelines as well. So why we should give a combination pill? Why we should compare valsartan with amlodipine, and why not give it separately? So these are all the big trials that we have seen. And if we see the hypertensive medications in these trials, there have been more than 2 medications in all these big trials, including UKPDS. And this means that you have to give minimum 2 medications for hypertension in most of your diabetes patients or hypertension patients. And this is why combination pill is a win-win situation for the patient as well as for us, because we need to control hypertension. Now, if you see this is a single pill combination, the green line, which is much better than the free combination or the monotherapy in terms of controlling hypertension. Let's see the guidelines. Do the guidelines say that we need to combine medications? Well, this is the American Heart Association guideline, and they say initiation of antihypertensive drug therapy with 2 first-line agents of different classes, either as separate agents or in a fixed dose combination, is recommended in adults with stage 2 hypertension and an average BP more than 20/10 above the blood pressure target. Anybody who's more than 140/90 to begin with, you can start with a dual combination pill. And again, if you see the European Society of Cardiology 2018 guideline, even they say that the initial therapy, you can use a drug combination, 1 pill, either an ACE inhibitor or ARB, adding to a CCB, calcium channel blocker, or a diuretic. So again, they say that you can start with the dual therapy, but if the patient is old, more than 80-year-old, or this is a low risk grade 1 hypertension, then you can use a monotherapy. Otherwise, start with a dual therapy. And again, if you see, this is the European Society of Cardiology guideline, whatever the blood pressure, and I'm trying to emphasize again and again that lifestyle therapy is absolutely essential. I mean, our patients should know that this is not something that they are not doing diet and exercise. They're eating a lot of salt. They're eating a lot of tail and ghee and all these things, and they're going to come us for diabetes and hypertension. This should not be on, and our patients should be very much educated to know that minimum half an hour of exercise a day should be mandatory for them. So again, if you have high normal blood pressure, more than 130, 85, then you consider drug treatment in very high risk patients. But if somebody has grade 1 hypertension, 140/90, you usually start with drug treatment. So again, the clinical evidence with amlodipine and valsartan. So we know that both valsartan and amlodipine, they are beautiful when it comes to blood pressure control. They both control the blood pressure pretty well. And we see that BP lowering efficacy and get to goal rates are better in both. Efficacy in non-responders to monotherapy, efficacy in non-responders to other combination therapy. And they work in all grades of hypertension with relative the beautiful safety and tolerability. So when we combine amlodipine and valsartan, you're actually dropping the systolic blood pressure by as much as 43 millimeters of mercury and the diastolic blood pressure as much as 21 millimeters of mercury. And this is fantastic. This is comparison of the valsartan amlodipine, the blue to purple bar with the yellow lisinopril hydrochlorothiazide group. And again, if you see the BP lowering efficacy, alone amlodipine, alone valsartan, when you combine these both valsartan and amlodipine 10 by 160 milligrams, you get a fantastic blood pressure reduction in your hypertensive patients. So again, when you're giving amlodipine and valsartan, 9 out of 10 of your patients can reach blood pressure goal at week 16. And this, remember, is only possible when your patient is is also doing lifestyle modification as well. So again, when we talk about safety and tolerability, we know that one side effect of amlodipine alone is the fluid retention. And we sometimes see pedal edema, especially in the old patients that we have with amlodipine. And when we combine the amlodipine with valsartan, this problem of pedal edema or fluid retention becomes significantly better, coming down from 23% in amlodipine 10 milligram alone to around 6.8%. And this is beautiful, you know, when patient, you just combine this tablet with valsartan amlodipine and it just starts to go away. Again, when you see the combination of amlodipine valsartan compared with amlodipine atenolol has lesser recurrence with the atrial fibrillation. So amlodipine valsartan in terms of atrial fibrillation is lower recurrence of atrial fibrillation as well. So coming up to the summary of hypertension treatment and management, the combination of amlodipine valsartan FSAR, the single pill combination shows powerful blood pressure reduction, superior efficacy across all grades of high blood pressure. And the important thing is that time has come for both diabetes and hypertension that we begin with dual therapy. Even in diabetes, beginning with the dual therapy now seems to be much better after the verified trial, in fact. And even before that, we all know, and even in hypertension, time is coming that we start with dual therapies. And then again, safety and tolerability is fantastic, superior therapy adherence. Thank you very much for attending, and I hope, Atik, your YouTube participants also enjoyed attending this. Once again, thank you very much, FARMUO, for organizing this CME on hypertension and again, giving us an opportunity to learn. And I'm grateful to Sir Professor Najmul Islam for being here to guide us once again. Thank you very much, to all the participants as well.
Dr. For a wonderful talk on hypertension. It's very important to have hypertension. Blood pressure should be controlled among patients who remains uncontrolled on other drugs or on other with other comorbid situations. Now I have few questions from my participants on the YouTube, and I would like Dr. Najam to kindly answer these questions. Sir, may I ask questions?
Yes, please. You ask me and I'll try to answer.
Okay, sir, Aslam is our participant on YouTube. He is asking, what if patient landed in ER with high blood pressure of 180 millimeter of mercury, then what should be our approach?
Okay, 180 systolic is not something that should land up in the ER. A hypertensive urgency or hypertensive emergency is slightly different, and that is dealt in a different way. Patients do come with this sort of systolic blood pressure 180 and a diastolic of 90 or 100 to us in the clinics. So unless the patient has got into a heart failure because of hypertension or has got an organ damage, which is an hypertensive urgency and emergency, that is different scenario. So, but 180 systolic, I mean, can be managed adequately in an outpatient setting.
Okay. So second question is that practically there is a very less chances to start with lifestyle modification, either patient not agreed or it's too late as complications are there. So do we go for step 1 or step 2 of combination therapy? Yeah, this is a question from
It
sir
all
here.
depends. It all depends at what stage, at what sort of blood pressure levels the patient has presented to you in the clinic. If the patient has already a very high blood pressure, then you may consider lifestyle modification along with maybe dual combinations together for blood pressure control. But if somebody has come with a blood pressure of 140, sort of 138, 40 sort of blood pressure, so that can be tackled with lifestyle alone. So that Ali has shown that in his lecture. So scenario will change, but I mean, we cannot rely too much on lifestyle, at least in our population, knowing that they do not adhere to it very much. So yes, but in borderline cases, we can give some time for lifestyle modification alone.
Right, sir. Another question is about the new drug SGLT2 inhibitors. Do we combine dapagliflozin with this combination to reduce the probability of heart failure? I think
Yeah, I
इन्होंने
mean,
preventive उसमें पूछा है.
in it, prevention की तौर पे तो नहीं है. I mean, there's no need for giving DAPA because just to prevent from heart failure. But DAPA as such is a good drug. Dapagliflozin and empagliflozin as a good group of drugs for management of diabetes with benefit for cardiovascular benefit as well as renal benefit. So in that context, you can use it, but not just because the patient is hypertensive. If we start giving dapagliflozin as well to prevent from heart failure, that is not indicated really or justified. But if the patient is diabetic, you might as well use this drug for the benefit that I have told you.
Okay, and so far I know that there is no trial about dapagliflozin or empagliflozin on the reduction of hypertension.
As such, I mean, in all the trials that have been done, there is reduction of blood pressure in patients
Okay.
in whoever on this SGLT2 inhibitors, but no separate trials have been done looking at blood pressure, to my knowledge. But in all the trials that have been conducted on these SGLT2, almost all have reported some reduction in blood pressure.
Okay, so one more question. Since we have a triple combination in the market and they are very cheap, so can we replace double combination with triple combination for the management of high blood pressure?
No, I mean, if your patient needs it, yes, definitely you go for triple combination. But if your patient is well controlled on a double combination on two drugs, why to go for the third combination? I mean, you can leave it for a later time when the blood pressure is uncontrolled. You can go for the three agents together
Okay.
because there are double combination, triple combination, and there are single drugs. So it all depends on the level of blood pressure of your patient. You don't start triple combination from the very beginning in a patient who has got a mild hypertension.
Right. The other question is about comorbids. What should be our targets for patients with comorbid as they have a burden of polypill as well and some of other issues?
You mean the target for blood pressure control levels? I mean,
I think so.
obviously,
They are say.
uh, uh, I mean, for all patients, we should be aiming for blood pressure at least less than 140/90 millimeters of mercury. For patients with ischemic heart disease and patients with renal disease, we should be aiming for 130, 135, 80, 85 sort of diastolic blood pressure and below.
Right. I think, yeah, one more. What equipment, digital or conventional, is better to use in GP's clinic as well as for home readings? How many readings should we take for diagnosis?
I mean, obviously, you should not make a diagnosis and start treatment on a single reading. That is because, and the clinic setting is in some patients, they have got this white coat effect and the blood pressure goes up. So the best place to record blood pressure is at in home setting. So if the patient or the attendants can arrange to get the blood pressure checked at home, that is the best thing. If you are having difficulty, then you may take help from ambulatory BP recordings to decide whether your patient is hypertensive. But there are many patients who come with white coat effect and they tell us, okay, we are checking blood pressures at home and it is well within the normal range, but only when in the clinic it tends to go up, particularly the systolic goes up in white coat in the clinic setting, which is called white coat effect. So single reading to nahi hai, multiple readings chahiye at in different time well apart, and only in patients with got a hypertensive urgency or emergency, the scenario is different where there is an urgency to start treatment.
Right. So Dr. Nilofar Fahad is asking, in case of secondary hypertension in young patients, what would be the conventional therapy before and after surgery? If there is pheochromocytoma or paraganglionoma, what will you answer?
देखिए अगर obviously
मैं ऐसे दोबारा repeat कर दूं?
I got me. I understood what the doctor sahab is asking. Basically, pheochromocytoma patients, the blood pressure is controlled with an alpha blocker and a beta blocker combination prior to surgery. And after the surgery, we expect that the blood pressure will be controlled without medications, unless and until the patient has been hypertensive for a long time, then the pressure may not normalize, but the medications will go down. So in that setting, alpha and a beta blocker is preferred over the other medications that Ali has talked about.
Right. So I think so. There are a lot of questions we have asked so far, and I would like to now end up the session. Dr. Najam, can I ask you for conclude the session?
Yes, thank you, Fahmi, for inviting me in as a panel of expert, or just an expert, not a panel because there's no panel. The speaker, I would like to thank Ali Asghar for his comprehensive talk that he has given. He's a good speaker. It doesn't matter which topic he has given, but he speaks very well. And the content of his talk was also very good. And I think it covered the main aspects of hypertension, the importance of getting it controlled, and he did talk about the differences that the Europeans have, and as compared to Americans, the Americans are more aggressive in terms of blood pressure control as compared to the Europeans. So I think that has been nicely covered, and I would like to thank Ali Asghar for his comprehension and for the participants who have listened with patience on the whole talk. And in the end, I would also like to thank Fahmi for arranging this webinar.
Thank you, Professor Dr. Najmul Islam, for your nice words. And Dr. Ali Asghar, would you like to comment?
Yes, thank you very much, Atiq. Thank you very much, Professor Islam, to have you here. It's always a pleasure to see you and get blessed from you. Thank you very much for being here. Thank you very much once again, Atiq from Famibo, for organizing this, and thank you to all our participants, whether they are here on YouTube or Facebook, for attending this. Thank you very much.
Thank you so much, Dr. Ali Asghar and Professor Najmul Islam, for your valuable time for the audience. Audience, I would like to thank you for all for listening us patiently. And if you have any question, you can write on our YouTube page, Cardio TV. You can ask us anything, and Dr. Ali Asghar or Dr. Najmul Islam will answer there your questions. Thank you so much.
Thank you. Khuda Hafiz, everybody.
Allah Hafiz, sir. Allah Hafiz.
Allah Hafiz.